Thank you for joining today's webinar, Practice-Based Insights to Help Optimize Endocrine Therapy Duration in Early Stage HR-Positive Breast Cancer. My name is Susan Hepworth, and I will be facilitating today's webinar, which is hosted by Biotheranostics, a Hologic company. We are pleased to be joined today by Dr. Grace Bingham of Biotheranostics, who will moderate today's webinar. Dr. Bingham will be joined by Dr. Rena Callahan from UCLA and Dr. Vijay Paryani from Duke Health. Today's agenda is as follows. After this very brief welcome that I give, Dr. Bingham will lead a discussion with Dr. Callahan and Dr. Paryani for about 45 minutes. As part of that discussion, Dr. Bingham will prompt a few different poll questions throughout, so be on the lookout for those to appear on your screen throughout today's webinar. And then we've reserved time at the end for questions from the webinar attendees, and we'll conclude right at about 8 p.m. Eastern Time. We encourage you to submit your questions using the Q&A button on your screen, and you may submit those at any time during their conversation. There's no need to wait until the end to submit your question. And with that, I will turn it over to Dr. Bingham to lead today's discussion.
Thank you so much, Susan, and thank all of you for coming tonight for our Breast Cancer Awareness Month webinar. My name is Grace Bingham, as was mentioned earlier, and I am the Oncology Medical Science Liaison at Hologic, who will be helping to moderate tonight's discussion on a really critical point in breast cancer care. And that is how to best optimize endocrine therapy duration for each of your patients. We are fortunate to be joined by two expert hematology oncologists, Dr. Rena Callahan, who's over at UCLA on the West Coast, and then on the East Coast, we have Dr. Vijay Paryani. Both of our experts focus primarily on breast cancer and will be sharing some insights that they've gained over the year and how they approach individualizing care for each of their patients. To start, could each of you share a little bit more about what led you to focus on breast oncology as well as your practice, starting with you, Dr. Paryani?
Hi, Grace, and hi, everyone. Thank you so much for having me. My name is Vijay Paryani, as she said, and I'm a breast oncologist at Duke Health. I got into breast cancer because I watched my youngest aunt die of metastatic disease when I was 12 years old. So that was really foundational for me, and I just wanted to say, I need to fix that, wherever that is, we're going to fix that. So that's what shaped my career. And now it's such a rewarding and lovely line of work. I see patients in mostly clinical, but I also teach students, fellows, and I am actively involved in clinical research. I have been principal investigator on a couple of clinical trials, and I'm so grateful to be here. Thanks for having me.
Yeah, thank you for sharing. I think it's really powerful to hear that you have this intimate connection that's placed you and inspired your work. I know I'm in my current position because of my own experience with cancer in my family, and I think that probably resonates with a lot of people in the audience. What about you, Dr. Callahan?
Yeah, so BJ, that's so beautiful. It's interesting. We have this profession, but there is this personal connection that so many of us have. For me, it was when I was in medical school. My uncle was going through colon cancer. So there were no other doctors in the family. I learned everything I could about it. Ultimately, he had a long battle, 7 years long for colon cancer, but eventually succumbed to it. And so that drew me towards oncology. And then your career can go in different ways. I thought I was going to do GI cancers, but then throughout residency and then fellowship, I was always drawn to patients with breast cancer because it was like, in some ways, looking in the mirror, right? People with whom, or women with whom I could just intimately relate as a daughter, as a mother, as a sister. And then the science behind it is really amazing, and just the explosion of new therapies, so that you also have that, they have that personal connection, but also that scientific, stimulation. It never ends. So it's been a great career at UCLA, where I've been for over 15 years.
Wow. And It's amazing to hear that you've been there so long, helping so many patients for so long. And I think both of your experiences really highlight the kind of people who are attracted to breast oncology. All of you are really compassionate and committed to your patients. I mean, it's why there's so many people attending this webinar because you guys are always trying to advance your care, always trying to make it better to impact that patient's lives. So that leads us nicely into us discussing how we can better tailor endocrine therapy decisions for endocrine therapy and hormone receptor positive patients. Before we go into the data discussion, I'd like to do a quick overview of the agenda so everybody knows what we'll be going through today. After a brief overview of the breast cancer index and some of the data supporting its use for helping personalize that endocrine therapy decision, we'll review the genomic assay landscape in its entirety. Next, we'll discuss recent findings from the Lancet meta-analysis, and then we'll go over some patient cases with Dr. Callahan and Dr. Paryani. Finally, we'll open it up to you all, the audience, to conclude the talk and to go through some Q&A. And with that, I will turn it over to Dr. Callahan for an overview of the breast cancer index.
All right, so thank you, Grace. So this slide depicts the two tests that are part of the breast cancer index test. So it's a genomic assay that is supporting decisions on whether or not to extend endocrine therapy in patients who have both negative lymph nodes as well as positive lymph nodes, up to 3 nodes that are early stage and hormone receptor positive. So let's go through the two parts of this test. So there is one part over to the right that is prognostic. And so what is a prognostic test? It gives you a prognosis, how likely it is for a certain event to happen. So in this case, it's distant metastases between years 5 to 10. And to create that prognostic score, which is a percentage, there is a combination of 11 genes, and those are shown also on this slide. These genes are involved in cell signaling as well, going through the cell cycle rather, and estrogen signaling. And there's also an additional algorithm that incorporates information on node positivity, tumor size, and grade that goes into coming up with this percentage. Then, and what I think is the most important part of the test actually, is the predictive portion of the test. So the predictive part of the test is just a ratio of 2 different genes involved in estrogen signaling, shown here, and that predicts, yes or no, is a patient likely to benefit from extending endocrine therapy or not? Just a simple yes or no. And so a lot of tests are prognostic, but it's really the predictive part of a test that helps you answer a very important question that can be used to make treatment decisions that is unique about breast cancer index. So then this is how it looks. Many of you in the audience might be familiar with this, but this report has changed over the last several years, and I think it has changed for the better so that it is very clear, and you can actually take this report. Sometimes I do telehealth visits and I screen share because I just love the report, and I think, some people are auditory and some are visual learners. That goes for our patients. And so what you see in the middle of the slide is a yes answer. So you get that predictive result up top. Yes, I am likely to benefit from extending endocrine therapy to 10 years. And then the bottom portion is the prognostic result. So on the left, that 8% there's an 8% risk of metastatic disease between years 5 and 10 for this patient. But if this patient chooses to extend therapy for another 5 years, that is reduced to about 3%. And so they can see this very clearly on the report. And then on the bottom right, that's the no answer. And so it's no, you are not likely to benefit from continuing endocrine therapy, and that the risk, right, the prognosis is 8% risk of metastatic recurrence between years 5 and 10, regardless of whether or not endocrine therapy is extended. So as a result of data, which you will see very soon, a lot of validation for this test. Breast Cancer Index is now incorporated into our two of our major guidelines. So NCCN as well as ASCO clinical practice guidelines. And they both say very similar things, but the wording is a little bit different. So NCCN, it's stating that in an analysis of several trials, including MA17, Transatom, Ideal, that patients who had hormone receptor positive, T1 to T3, node negative or node positive, who had BCI, where the answer was yes or high, that they had significant improvements in disease-free survival when their adjuvant endocrine therapy was extended compared to control, and that if it was low or no, that they did not. And then ASCO reads that BCI can be offered to patients with 0 to 3 positive nodes who've had 5 years of endocrine therapy without evidence of recurrence to guide decisions about extending endocrine therapy, and that you can offer BCI if a patient has had tamoxifen AI or sequential therapy, and then goes on further to say that Oncotype DX, EndoPredict, Prosigna, Ki67, IHC4 as having insufficient evidence to guide these decisions about extending endocrine therapy.
I completely agree, Dr. Callahan. I think one of the most, I don't know why I said that, Rena. I completely agree. One of the most important things about this is the usability of the test in clinic. It's just such a easy thing for a patient to understand, for doctors to understand. I do the same thing as you. I usually say, okay, we'll send this, and then we'll do a telehealth visit. You just from the comfort of their own home, we can throw it up on a Zoom just like this, and
Right.
it's actually, it doesn't even take that long to go through. And patients, I think their satisfaction, their comprehension of what's going on is drastically increased.
Right. And I used to have these conversations without this, and they go so much better with this.
I think you both bring up some really great points, especially about the utility of how it's reported, but also bringing it back to the incorporation of BCI into both the ASCO and NCCN guidelines really highlights the value of using genomic assays in clinical practice. And so I want to pose the following key question to the two of you. Why do you think it's important that we incorporate genomic information into patient care rather than relying solely on traditional things like clinical and pathological factors? Starting with you, Dr. Paryani.
I think that's a great question. And to put it simply, we're in an era of precision medicine, right? There's a lot of many widely available, powerful, valuable genomic assays in all cancer types, and especially in breast cancer. And we are comfortable using a lot of these different genomic assays to make treatment decisions. So I think in general, it's trying to get us away from a one size fits all approach. I mean, it's specific to endocrine therapy for breast cancer index. This is a genomic assay that can guide us because we know clinical pathologic features alone don't predict the benefit of extending endocrine therapy. So, by helping us find out exactly who's going to benefit from extending therapy, I think it really helps us gain patient buy-in and validates the patient's efforts. Because that journey of 5 to 10 years of endocrine therapy, that's a long and arduous road. And it's one that's potentially filled with a lot of different side effects. So precision medicine really helps guide us along that path.
Yeah, I mean, I completely agree, VJ. Our patients, they don't want to feel like they're a number, right? And so a lot of times we get really into statistics, and then you can just see them kind of turn off a little bit because they want to know that you're making a decision for them and not for somebody else. Right. And so this is that precision medicine. So when you say, okay, we're going to take your tumor and look at the genes in your tumor that have been validated, in this test to help make us this decision. Absolutely. As you said, VJ, the buy-in is totally different, right? Because they're no longer thinking, oh, well, that's just a statistic, and maybe I'm this part of the statistic or that part of the statistic. No, these are the stats for you, and this will help you make a decision. And then I found that, when we use this, not only is there initial buy-in, but there's buy-in as we go deeper and deeper, right? As you said, it's a long and arduous road. But you don't have them at every visit saying, can I quit? Can I quit? Can I quit? How much do I need this, etc. I think it's really helpful in getting us all to agree that yes, we're going to go for a full 5 years, a whole other 5 years without as much of that. And then the focus is on, okay, how do we get through it? Right? What are the things that can be done to make it better for you?
Absolutely.
Yeah, this discussion honestly perfectly sets the stage for our next topic, which is a discussion on how we can use genomic tools like BCI to personalize care and avoid over and under treatment. Let's begin this section with a poll from our audience. If everyone out there could answer the following question: among early stage hormone receptor positive breast cancer patients with N1 disease, so 1 to 3 positive nodes, what percentage do you typically recommend extending endocrine therapy to a full 10 years? Oh, lots of participation from the audience. And we'll have about 30 more seconds to answer this question if you haven't already.
Feel like we should have music here.
Right?
Little Jeopardy theme.
Right, right.
Okay. Looks like the results are in. And it seems like most people use a genomic assay to decide, which is
I love
great.
seeing that.
Yeah, love to see that. Do you guys have any thoughts? What do you do? What would you do in this case? Dr. Paryani, and then I'll go to Dr. Callahan.
I personally I'm in camp C. I use a genomic assay to decide. Specifically, I'm very comfortable with breast cancer index. I think it's been robustly validated as we're going to discuss. But I think I used to before I became more comfortable with BCI, I probably would have been in camp B as well, and I can see there's a significant portion of people who are. I think that's part of our natural protective instinct is when a patient's clinically high risk with positive lymph nodes, we do often want to default to a longer period of endocrine therapy. But I do think that decision needs to be weighed pretty carefully because it could be potentially overtreating.
Yeah, and I thought that it was interesting. It's this question is to us, right, as providers, what do we recommend? But the reality is that, you're not there with the patient making her take it every day. So we can recommend whatever we want, but they have to buy into it. So I use genomic assay and I use breast cancer index to help with these discussions for sure. All right. So, node positive. So the reason that poll was really trying to get you to describe what you do when someone has clinical high risk features. I think we can agree that node positivity is a clinical high risk feature. And while several years ago, it was our inclination to say, okay, high risk means we have to intervene in a certain way. And in what ways can we intervene? Well, one way we can intervene fairly easily, for us anyway, as the providers, is to prolong our recommendation on how long the patient needs treatment. But it doesn't always go together, right? High node positive doesn't mean benefit from longer treatment. And so this is data from an analysis that was done. It was a prognostic validation study of over 400 patients from MGH, I think between the 90s and the mid 2000s, where BCI was applied to tissue blocks and identified 22% of node positive patients of actually having a limited risk of late distant recurrence. And of those, about 70% were not likely to benefit from extending endocrine therapy. So it really helps us avoid overtreatment and also helps the patient, reframe perhaps their own risk, right? Because there's a lot of scaring that goes on that we use to get them to be compliant with endocrine therapy. But sometimes if they don't need it, they can back off from feeling like they are very, very high risk for such a long period of time.
So these were, breast cancer index now has been validated in over 2,500 node positive patients across these foundational validation studies. You can see these patients here across these studies, they had different treatment histories and they were evaluated with some form of extending endocrine therapy. But what's really profound here is the amazing positive and negative predictive benefit, ability of BCI. So in patients who were BCI high with a yes predictive result, there was a consistent risk reduction of around 60 to 70% with extended endocrine therapy. And in patients who had a low predictive result or a no, they had no significant benefit in extending endocrine therapy. So, and as a reminder, there's a large portion of these patients in these studies were lymph node positive, as you can see highlighted below. So this is why breast cancer index is included in NCCN and ASCO guidelines in a wide swath of patients up to T3 in size and up to 3 positive lymph nodes.
Yes, Dr. Callahan and Dr. Parani, they just gave us some really insightful information about those clinically high risk patients who might be at risk of overtreatment. And this prompts an equally important question about the converse scenario. What is the best practice for managing clinically low risk patients? For example, those with T1N0 disease. To better understand the current perspective of those in the audience, let's do another quick poll. If everyone could answer the question, what duration of endocrine therapy would you recommend for a patient with early stage hormone receptor positive, clinically low risk breast cancer, such as T1N0? Cue the Jeopardy music.
I would sing it or hum it, but then I think the attendance would drop.
Yeah.
We would see the
Is
ticker going
everybody
down.
is everybody wearing pink? I saw Dr. Priani, Dr. Callahan. What about you?
Oh, I don't have pink, but there we have much of the staff have t-shirts that they're allowed to wear this month. And they have one more day. So, but it's Halloween tomorrow, so who knows what the office is going to look like.
Right. I mean, you have that amazing poster in the background, so I think it covers all the bases. All right. Few more responses trickling in, but it looks like overall, those of you in the audience would recommend 5 years for this patient. So I'm now going to see what our two experts think about that. Dr. Priani, what are your present thoughts on this?
That's really interesting. I was expecting some of I think in my mind I was expecting a little bit of a little bit more of a balance. I feel like T1N0, one of the things that I think if you're being specific, you'd have to delve into T1 a little bit. Are we talking T1A? Technically NCCN guidelines would actually say for T1A and zero disease, consider adjuvant endocrine therapy. But if it's T1C, that could be all the way up to a 2.0 centimeter tumor. So it's a wide question, but I do think that is historically quite standard to recommend 5 years of endocrine therapy. But again, we know, as this point, I feel like a broken record, but clinical pathologic features alone don't necessarily predict the value of endocrine therapy. So I think in my current practice, I am optimistic that it will be 5 years, but I keep an open mind, and it is difficult, but I ask my patients to also keep an open mind to the potential that they could benefit from a longer duration of endocrine therapy.
Right, exactly. I noticed on this poll, there was no send a genomic assay option, but option E is what I would take.
Agreed.
All right. So this is the flip side of what, I spoke about earlier, avoiding overtreatment. We also have to avoid undertreatment, right? Because what is undertreatment? Undertreatment means that a patient has developed a metastatic recurrence, and that will very likely take her life. So we need to be careful about these patients. So these T1N0 patients, we're assuming that they're low risk, they're clinically low risk. But in this particular study, uh, picking out those clinically low risk patients. So this was an analysis of multiple cohorts at Pitt, at MGH, Stockholm, looking at these T1N0 patients. And BCI was able to identify about a quarter of them as likely to benefit from extending endocrine therapy. And not just that they were at high risk of late distant recurrence. So, a test like this, it allows you to pick out that wolf in sheep's clothing. We have those conversations all the time surrounding chemotherapy. We should have those same conversations surrounding extending endocrine therapy. All right. So how about, sometimes we just want to hedge, right? Does it have to be 5? Does it have to be 10? Isn't there gray, everything in moderation? Well, not always. So uh, the SALSA trial, the ABCSG SALSA trial came out that looked at 7 years. And so there was a lot of talk about, oh, is 7 years actually the right number for extending endocrine therapy? But in this trial, the ideal trial, so this is a trial that after 5 years, had patients take another 2.5 years or an additional 5 years of therapy. And so when BCI was applied to tissue blocks from these trials, if there was a no, there was no benefit of extending from 7.5 to 10 years. But if it was yes, there was a 10% benefit. I mean, I think most of us can agree that is a very large benefit from just 2.5 years of additional therapy. So this just, highlights how sometimes hedging, and just picking somewhere in between isn't good enough.
I love this slide. I think this slide is what real biomarker separation looks like. It's a very clean example. And there's actually data in this same analysis of ideal for when you filter out tamoxifen, so base AI therapy, then extending to adjuvant, extending the AI, it yielded a 6% gain in reducing recurrence in all comers. But again, breaking it down, there was no gain in BCI low patients and almost 12% reduction in patients who are BCI high. So I think it's really going back to that last poll question. I think it's really important to really weigh carefully the decision of extending an AI because AIs are we know they're tremendously effective drugs, but they can be quite challenging. The incidence of the AI musculoskeletal syndromes around 15 to 20% in most trials. Osteoporosis risk exceeds 10%, fracture risk somewhere around 10 to 15%. And those are not subtle or mild side effects. So I think BCI really, truly reliably identifies patients who benefit from that extension. And as we saw before, it has extensive validation.
Let's now transition and discuss some of the genomic test options that are currently available to help inform treatment recommendations in early stage hormone receptor positive breast cancer. And since there's a range of assays at your disposal, I think it would be helpful to again understand what is happening with everyone in the audience and see what they're utilizing with another poll. So if everyone can answer which genomic test or tool do you primarily use to inform extended endocrine therapy decisions in early stage hormone receptor positive breast cancer? And then for this poll, there's quite a few options, so you might need to scroll down to select your particular option. Awesome. You guys are rapid fire with your responses. Love an engaged audience. Okay. So far, we do have a leader, but there is a few responses in some of the other categories. Right now, breast cancer index is leading, so it seems like people have been paying attention to the first part of the talk or have heard the talk before. We have a few responses for MammaPrint, and then right now we've got 22% with Oncotype DX, and then one person who's using CTS5. So what I want to now pose the question to the two of you, which genomic assays are you using and why are you using them when you're using them?
In clinic for um, as far as genomic assays go in decision making for chemotherapy, I actually think a lot of these are great assays. I have no issue with any of them, but my preference is Oncotype for the decision regarding adjunct chemotherapy because just the robust data they have. Taylor X was such a beautifully designed trial, and its track record is stellar. For extending endocrine therapy, my preference is BCI, and I think the validation of that assay speaks for itself.
Yeah, I mean, I use Oncotype for adjuvant treatment, chemotherapy treatment decisions, and then I use BCI for extended endocrine therapy. I will occasionally send MammaPrint. It is usually in the setting of neoadjuvant treatment. I have someone, I want to give her neoadjuvant therapy, but I'm not sure that chemotherapy is going to work very well. So I will send it in that setting, but I don't use it to make extended endocrine therapy decisions. I don't, from what I've seen of the data, it's not enough for me to use it for that purpose. I don't know about you, BJ, whether you use it at all, what your familiarity is with it, some of the data.
Right. So, I mean, if we're talking about extended endocrine therapy decision making with MemPrint, I mean, I don't know how many people in the audience are familiar, but there were two papers last year. One was in JCO, that was their analysis, their recent translational analysis on B42, and then in JAMA they presented their secondary analysis of IDEAL. So, kudos to them. That actually they're really well written papers. They actually recognize BCI's predictive ability and inclusion in guidelines as well in their paper. So my takeaway from MammaPrint data is, both of those analyses were asking if MammaPrint changed how much benefit you get from endocrine therapy when you're focusing on distant recurrence. So the interaction test in those trials were both negative. I think an interaction test is a great way to answer that question, but the interaction for distant recurrence was not significant. So the primary predictive hypothesis of is MammaPrint predictive for distant recurrence was not confirmed. So, in my opinion, that shows to me that MammaPrint high risk patients benefit less. It doesn't show that they benefit less from extended therapy. It just simply showed that the difference between MammaPrint high and low groups was not statistically significant for distant recurrence. So, if for MammaPrint high, it would suggest that all those patients should be stopped at 5 years of endocrine therapy. I think that's a big risk of undertreatment with the patients with the worst clinical pathological features. And I think MammaPrint high risk just calls for integration of genomic and clinical factors, not automatically truncating therapy.
Right. Yeah, I mean, it would be great if there was just one test and we could use it for everything, but sometimes it just doesn't work that way, right? And so at least right now with the available data, this is a review of the NCCN guidelines. And so we have many of the players here, the genomic assays that we use. You have Oncotype for node negative, 1 to 3 positive nodes. You have MammaPrint for node negative and node positive, Prosigna, node positive, negative, and EndoPredict, and BCI is at the bottom. And so the oncotype is both predictive and prognostic, but it is predictive of chemotherapy benefit, right? And that's where we use the test, and that is where we should use the test. Breast cancer index, however, is both predictive of extending adjuvant endocrine therapy as well as prognostic. So that is where we should use the test. So if we're following guidelines, then these are the tests that we should use. And this is a reminder of when we should use them. So just to call out again, the ASCO clinical practice guidelines, which you saw earlier, call out Oncotype, EndoPredict, Prosigna, Ki-67, and IHC4 as having insufficient evidence to guide extended endocrine therapy decision making. All right, so I thought that this was a very interesting analysis. So these are patients from the Trans ATAC trial, and BCI and Oncotype were compared head to head, right? Are they all saying the same thing? So when applying BCI, 27% of patients in this analysis were re-stratified from having a low Oncotype score into having a high risk of late distant recurrence. Right? So that's really important. Just because the Oncotype recurrence score is low doesn't mean that they don't have a high risk of late distant recurrence, and you might want to do something about that. So that there is this proportion, about a quarter of Oncotype low risk patients who have an elevated risk of late distant recurrence, and we need to keep that in mind. And this just highlights that you cannot use one genomic assay, which you're using to make a decision about chemotherapy, to make a completely different decision.
Yeah, now let's talk about some of the more recent data that has been published in this space. Dr. Pariani, can you please give us a brief overview of the recent Lancet meta-analysis and what it found?
Sure. This was a recent meta-analysis published. It was from the Early Breast Cancer Trialist Cooperative Group. This is individual patient data from 12 randomized trials, including more than 22,000 postmenopausal women with early hormone receptor positive breast cancer who had already completed at least 5 years of endocrine therapy. The question was whether extending adjuvant endocrine therapy with an aromatase inhibitor provided an additional benefit. So the primary outcomes were recurrence and mortality. That includes distant recurrence, contralateral events, and breast cancer specific and all-cause mortality. Secondary outcomes included adherence and bone fractures, and that, as we know, that has major implications for long-term tolerability. The median follow-up on this trial was roughly 8 years. So the extended endocrine therapy, in these graphics, it shows extended endocrine therapy reduced recurrence by about 27% with a relative risk of 0.71. So that's 11.6% versus 15.2% recurrence between years 5 and 15. With extending AI therapy, distant recurrence was also lower, 6.6% versus 8.6%. However, breast cancer mortality was not significantly reduced. Fracture risk was increased, and adherence fell to around 60%, although the same thing happened in the placebo group. So that's an interesting thing to tease out in this trial. So, this trial, I think it has an interesting takeaway. It has some strengths and some weaknesses. I think the strengths of this trial are its very large scale and its follow-up are impressive. And it lays the groundwork for the concept that extending endocrine therapy works on average. I think there's some things you just took points of caution to point out is that there's heterogeneity among those trials. The absolute benefit was modest, and there was no biomarker stratification for in any of these trials.
Yes. And then Dr. Callahan, do you have any comments on that about what your thoughts are for a study like this and its relevance on personalized care?
I mean, it's important to have meta-analyses because, as Vijay said, it tells us that on average there is a modest benefit of continuing anti-estrogen therapy. But there's nothing personal about this, right? When you talk to patients, you're like 7,000 women, that kind of thing. That is not personalized at all. And so you want to be able to say, to go from, oh, this helps by 3.5% to, oh, this doesn't help you, or this helps you, 10%. So I think that's where we have a genomic assay. If for whatever reason, in an under-resourced situation, we did not have a genomic classifier, then sure, this is important data to have. But we are not in that position, at least, in the United States right now. So I think we should use something that's more personalized. We tend to talk about, bone fractures, and I completely agree. A hip fracture could be a death, but there's so much more than that, right? There's just the day to day. I feel fatigued. I feel old. I feel basically depressed as a result of feeling fatigued, old, and achy. And then the cognitive effects. I mean, I think that is really concerning, right? What does 10 years of extreme estrogen deprivation do to a woman, especially depending on where they are in their lives, right? Maybe between the ages of 40 and 50. What does it do? So I think important, but I still need more in making that type of a decision for a patient, given the potential toxicities.
I think it's also interesting to note, BCI was validated in three of those 12 trials, Ideal, Salsa, and
Right.
B42. So, I think this meta-analysis, it proves, extended endocrine therapy works in general, but it doesn't really tell us exactly for whom that matters.
Yeah, actually, four of the five studies that we have done been validated in were included in that meta-analysis. But I think you both bring up really great points, and especially Dr. Callahan, you were talking about the individual patient and how it affects their life. And I think that beautifully ties into getting into the clinical case review. So with that, I will turn it over to you guys to discuss some of your patients and then also how you did your treatment recommendations based on the test reports.
All right. So this is my lovely patient. At the time of diagnosis, she was 40 years old. She was actually a principal at a school, and the school was located right across the street from our infusion center. So it was so cute. She had many of her coworkers out there with signs, saying, you know, good luck. We're thinking of you during your chemo. So she was 40, so premenopausal, 3.4 centimeter node positive tumor. She had, I think, 2 of 10 nodes positive, grade 1, ERPR strongly positive, HER2 negative, Ki67 15%. We did not send Oncotype. She was premenopausal with 2 positive nodes. At the time, I did not do that. She was given TC chemo, after which she had radiation and then was started on ovarian function suppression and aromatase inhibitor therapy. She really struggled with this. I mean, she worked so hard at getting healthy. She had a personal trainer, exercise, was optimizing her nutrition, but it was just really, really hard for her. Severe joint pain, her hair remained thin, mood swings, to the extent that she is no longer a principal. She is back in the classroom. She decided to, she just could not handle an administrative job like that. And so you saw a 40-year-old, who's at the top of their career, really being affected by this. And that's, heartbreaking in many ways. So then we ordered BCI 4 years after diagnosis, and these were great results, right? How great, because the expectation, at least initially, was that she was going to stay on it for 10 years, and it had just impacted her life in such a major way. But we got these results, no, 1.5%. So stopped endocrine therapy, and just feels better. She hasn't gone back to normal, right? Because there's no such thing as that. But she has definitely had an improvement in her quality of life. And I think that this helped me also, with those patients on ovarian function suppression and AI, that's really a murky area in terms of extending endocrine therapy. I mean, what do you think, VJ? Like, what do you do with your patients with OFS AI for 5 years? Do you extend them? Not sometimes.
I think I do the exact same thing you do. Like this is really powerful. This type of result. This is a patient who I think, again, in my earlier part of my career, I would have almost guaranteed have told her just get set for 10 years. So I think it is it's liberating and it's truly powerful. But OSAI, in my experience, it's brutal. I mean, I think people, especially this poor woman, 40 years old, it probably drastically changed her life. So, um, it this is why I think that this test is so important. And then I had a case of a very similar type of scenario in somebody who was struggling. So this is my patient. She was 62 years old. Um, I think this is a case. Actually, it's interesting. It really illustrates why precision medicine and biomarker guided oncology is important. So this was a T1N0 grade 1 tumor, strongly hormone receptor positive, HER2 negative. I don't know why that came back with an oncotype of 28, but that surprised us all. So she received chemotherapy, radiation, and she was on letrozole through a lot of different side effects. And so because of that, she was really struggling with those side effects. And around her, just entering that fifth year, I ordered BCI to see what she would really need to do. And that's another two that were a shock for me. The oncotype surprised me the first time. That surprised me the second time. So hearing that, you weren't going to benefit from extending your therapy and you still had a pretty big number left behind, that was a tough conversation. But it was a conversation that was very productive. So we shifted our discussion to, so what else can we do to help you reduce your risk of recurrence? And this woman became extremely motivated to make some really serious lifestyle modifications. She cut all alcohol out of her diet. She really fixed her diet and lost a lot of weight. I sent her to the Duke Weight Loss Clinic, and she, through aggressive exercise program, she actually started on a GLP-1. She's lost nearly 80 pounds, and she's totally transformed her life. So she has really, I felt like this led her to take her survivorship into her own hands. And I feel like even just like I called your case liberating, I think this liberated her in a way. She was like, it's on me now. And it
Mhm.
really, I think a lot of our patients, they feel, they go through this journey and it's a loss of control, right? So this really helped her. Have you had one like this, Rena? It's a tough
Yeah.
conversation.
Oh, yeah, absolutely. And some of these, I've had a no, 15%, that kind of a
Mhm.
thing, which involves multiple conversations. And I think you just have to steer the conversation and to not focusing on what won't work, right? But what might work. And so that is all of those lifestyle changes that a patient has completely in her hands. And then, I mean, not to open a can of worms, but there have been patients where I've sent ctDNA. I don't know what I'm going to, it's prognostic, but not predictive. And so, it gives us information, right? We have to be honest with our patients. They have to be able to have a realistic way to frame their risk. And sometimes it's this.
It's a tough one.
Yeah. So this is my patient who is 56 years old when she was diagnosed, had a 1.4 centimeter node negative, grade 3 ERPR positive, HER2 negative tumor, Ki 30%. Her oncotype was 22. So she did not have adjuvant chemotherapy. However, she had breast conserving surgery, so had radiation and then adjuvant aromatase inhibitor. And she did okay on it. She was fine. She really didn't love it and definitely expected to be done in 5 years. So somewhere along that 5 years, year 2 or 3, I started planting the seed that maybe we should think about this. And she's a very nervous person. So I think, it just we had to ease into this idea that just her small tumor did not mean that, she had no risk, right? That's why we set the oncotype. And so we had these conversations along the way. And then so we ordered BCI. And these were the results that yes, she was likely to benefit from continuing for 10 years, that if she stopped at 5 years, her risk of distant metastases between years 5 and 10 was nearly 15%, right? That's a lot. But unlike VJ's patient, she had something very clear that she could do about this, and that was extending her endocrine therapy. And she saw this and just, boom, that it's no questions asked. She said, okay, so I'm going to continue, right? It was just so clear. And so she continues on it, and she remains nervous, but feels like she is doing something to mitigate her risk. And I think it was helpful seeing these numbers.
This is the reason why now I am obsessive about, like, when I see a new patient, I say 5 to 10. I like write it
Yeah,
out,
right.
5 to 10, because I want you to remember that you might need this. And you and I both work in hospital settings where we see second opinions, like we see patients from all over. And when I get a transfer of a patient who moved from another hospital, it's always, I see a lot of oncologists that in their notes they're like 5 years. And so when I now am, someone's transitioning their care to me, I start thinking like, so what did you guys talk about? What was that conversation? Because I know like
Right.
that's another one that can be a tricky one, but it is an important one because of cases like this.
You're
And this
bringing
was
us to our last case.
Thanks. And then this is my other case. So this woman was 52 years old. She had a 2.1 centimeter tumor. It was node negative, grade 1. Again, strongly ER positive. PR was in the middle, 55%, HER2 negative. So she received local therapy and then was on endocrine therapy with all four pills that are on the market today. She tried all three aromatase inhibitors and tamoxifen. She had side effects with all of them. She had significant joint and musculoskeletal symptoms with the aromatase inhibitors. Tamoxifen, she had depression and a lot of sleep struggle. So she was motivated. She settled on exemestane and has been persevering. So with this one, I said, this is a perfect example of, we really need to know, why are we doing what we're doing? Is there meaningful gain to this? So BCI in her 5th year was sent, and this is the opposite of my second case in the sense of I had a pleasant conversation. So she received a result where she would benefit from endocrine therapy, but the absolute risk was very low. So these are my favorite conversations where, again, I mentioned in my previous case, it's about control. I think we've all, as clinicians, it's Breast Cancer Awareness Month, like we have all seen patients who are really, really struggling. They just feel like this cancer has taken everything from them. It's taken their hair, it's taken their relationships, it's taken their jobs. It's taken all control they've had over their lives. And when you see a result like this, it's again, an opportunity to get some control back, right? So for her, I said, just think on it. Whatever you want to do, I don't think you can make a wrong decision. There's probably some small gain there, but is it worth it when you're going through all this? Is it really worth it? So she smiled big, and we had a conversation, something along the lines of, it's like being at a restaurant with too many great choices and you can't decide what you want to order. Just pick one, you'll be all right. So she was very happy, and it was nice to see that an assay can generate that kind of instant satisfaction.
I've certainly had patients like this who have gotten the yes and then decided not to continue. So, when I think about these tests, they lay the groundwork upon which we have more nuanced, meaningful discussions with our patients. It doesn't tell you what to do. It helps you make the decision along with your patient.
Absolutely.
Awesome. And that finalizes our patient cases. Thank you both so much for sharing your personal experiences as well as what you've previously done in the past. I'm now going to open it up to the crowd for questions. And as those come in, I'll start with one. What do the two of you think of CDK4/6 inhibitors as it pertains to breast cancer index? Endocrine therapy and breast cancer care is constantly evolving. So this is one such example of it.
Yeah. So, I mean, I'll start. So, CDK inhibitors, clearly the validation studies did not include CDK inhibitors, but the way that I think about the test is that it's two tests. There's the predictive part and there's the prognostic part. And clearly, CDK inhibitors affect prognosis, right? So I would expect the use of a CDK inhibitor, perhaps maybe, to change that prognostic portion. But the predictive portion, whether or not a tumor is endocrine sensitive or not and likely to benefit, that yes or no, I don't think that changes. But of course, we do not have the data.
I agree. I feel like we're in different time frames and different mechanisms. I think CDK4/6, they target cell cycle proliferation. The HI ratio is really indicative of estrogen signaling dependency. So I think I don't see that I don't anticipate that biology would change, and I believe the predictive BCI results should be unaffected. So I completely agree.
So, okay, so this next question from the audience is, how do you explain to a patient who has had an oncotype that you also recommend a BCI?
I sort of frame it as that they are two separate tests. Oncotype is really going to answer the specific question of, do you need chemotherapy? As we pointed out earlier, the guidelines state that it has insufficient evidence to predict the benefit of extending endocrine therapy. So, I say, look, it had an incredibly important role in your journey. Like that test answered what might be the most important question you're going to have all along the way. Are you going to need chemotherapy? But in order to really give you the most comprehensive answer we can, as far as how many years of endocrine therapy do you need, I actually need a different test.
Yeah, I mean, I actually bring up Oncotype sometimes when I'm bringing up BCI. I'll say, remember that test that we sent several years ago to help us make a decision on whether or not you need chemotherapy? Well, the decision that we're making now is whether or not to continue your anti-estrogen therapy. And this is the test that can answer that question. Sometimes I've had patients that bring up, that are really getting into the weeds on the Oncotype test. It talks about recurrence between years 0 and 9. And then we have a discussion about how it has greater power to give us information on prognosis kind of in that first 5 years of that range. But I think it's we can make it pretty clear that the tests are useful for different things.
I found
Absolutely.
patients actually love it when you bring that up. They're
Yeah.
like, oh, yeah,
Yeah.
yeah, I remember
Right,
that.
right, right.
Yeah. So because we now only have a little bit more time, this will be our last question. When would you not send a BCI and under what circumstances?
Rena, you want to take it, or
Yeah. I mean, basically, if it falls out, and I've almost accidentally done this before where I've forgotten that a patient had 4 positive lymph nodes. And I brought up BCI, but then thought about it. And that's not, it should be sent for the population in which it is validated. And so if a patient has 4 positive nodes, no, you shouldn't send it. In some situations, there isn't enough tissue. Right. Sometimes, like if someone had chemotherapy, neoadjuvant chemotherapy and had a pathologic complete response, and you only had that core needle biopsy, or even if someone had neoadjuvant chemotherapy or any kind of therapy, you can't use the surgical specimen because it needs to be on the pre-treated specimen. So sometimes we run into issues like that. I mean, I used to think if a patient has her mind made up, we wouldn't send it. But then I found out your mind is not as made up as you think it is. Sometimes we've sent it. And this happens with Oncotype as well and chemo decision making. When you have that right in front of you, you might make a different decision. What about you, VJ?
I agree. I think that's my number one use case where I would not advocate for it is it has not been validated in N2 disease. So I don't think that that's an appropriate use for it. And other than that, I completely agree.
Awesome. Thank you both so much for taking the time to be here and provide your opinion. And that is the conclusion of our webinar. If everyone in attendance wouldn't mind providing feedback for our speakers, please scan the following QR code. And if we didn't have the time to get to your questions, we will be trying to follow up with you via email. Thank you all again for attending.
Thank you.
Thanks, everyone. Thanks, Grace. Thanks, VJ.